we're going to get started with the last presentation for today. And for those of you who don't know me, my name is Lindsay Weiner. I work very closely with Maggie and with the IPs here at our NHSN team. Okay, so my outline for today, I'm going to start by discussing the importance of data quality, which I know you've heard a lot about these past few days. I'm going to explain how to review and edit your data in NHSN. We'll then demonstrate the use of some basic analysis options to check the quality and accuracy of your reported data. I will then discuss reasons that your data may be included or excluded from all of the SIRs, and we'll end with tips to verify data accuracy for CMS quality reporting. So the importance of data quality. The data that you enter into NHSN are used for national aggregate analyses published in our CDC annual reports. So we take your data and we use it directly to calculate those location-specific pooled means and the national SIRs, which go right back to you and become the national benchmarks. Your data may also be used by your state health department or your hospital's corporation for any overall analyses that your state may do to assess performance. In order for the risk adjustment to be applied correctly, your data must be reported accurately and collected according to NHSN protocols. This includes the annual surveys, the denominator and summary data, and the events. So it's important on a regular basis that you are checking and confirming your data quality in NHSN, and any inaccurately reported data will result in incorrect SIRs posted to Hospital Compare. So the analysis functionality within NHSN was created in part to allow facilities and groups to be checking the accuracy of your reported data. We have some CMS-specific output options that many of you are probably familiar with, and these will let you preview the data that will be sent to CMS on a quarterly basis. We also have some quick reference guides on each analysis output available. They're available at this link here, and these are 1 to 2 page documents that will walk you through step by step how to modify each analysis output, how to run the output, and how to interpret the results. So I will start with the annual surveys. These are completed at the beginning of every year and should be completed based on your hospital's data from the prior year. There are variables from this hospital survey that are used for your risk adjustment. So this includes the total number of inpatient beds, the medical school affiliation and teaching status, and the primary testing method used for C. difficile for 2013 data. And Maggie mentioned this for 2014 data. We will be asking you to report your C. difficile test type once every quarter on the summary data entry screen, the last month of each quarter. And that is what will then be used for your risk adjustment. So if your survey data are incorrect, your SIRs will not be properly adjusted. So it's very important, especially before a CMS deadline, that you're reviewing your surveys, making sure that they are complete and accurate. So the annual hospital survey can be reviewed and modified following these steps. In the application, from the left navigation bar, you can click Surveys Find, enter in the requested information. The hospital survey data is your survey type, and 2013 is the year. And once you click Find, that survey will show up on the screen. You can scroll all the way to the bottom, and you'll see a button to edit. That will unlock the survey and allow you to make any changes you need to, and then click Save. We also have instructions that tell you details about each question on the survey and how you should be answering it, and that instruction form can be found here. Survey data can also be found in NHSN Analysis. We have a line list in the Advanced folder under Facility Level Data, and you can see we have several options for hospital, LTACs, IRFs, and dialysis survey line lists. And this may be especially important for groups who want to review the facility survey data. If they have requested survey rights on their group template, then they can run these line lists and view the survey data from each facility. And there are two revisions for the hospital survey, and you want to use version number 3. So your summary data, which are entered on a monthly basis, can be reviewed and modified in the application. From the left navigation bar, you can click Summary Data, Find, and enter all the applicable information on that screen. And your summary data will appear. And again, scroll to the bottom, you'll see a button to edit. So the summary data can also be found in the advanced folder. We have a summary data line list. And this includes denominator data entered for each month, location, and event type. So you can actually modify this line list to include helpful variables such as modify date, imported, and no events. So just a quick note about the modify date variable. I think this variable can be very helpful and is oftentimes underutilized. This variable will show you the last time that anyone at your facility has made a modification to your summary data. So this could be especially important if, for example, you are comparing your hospital compare preview report to the current data you have in NHSN. And oftentimes you may see a discrepancy. And remember, any changes you make to your data after the CMS quarterly deadlines will not be reflected on the hospital compare preview reports. So you can run this line list, you can add the modify date variable, and it can help you account for any discrepancies or changes you might have made to your data after the deadline. So you can review events using the line list. I'm sure everyone here is pretty familiar with that. It can be run in NHSN for each event type, and it allows for record level review of each event saved. And this allows you to check for data entry errors. It allows you kind of a first look at your data and really will help you assess the quality. This is the most customizable type of output in NHSN. You can add or remove different variables in the line list, and you can sort by a number of variables we have available. And on our quick reference guide webpage, we do have a one-page document explaining how to modify the line list. So another helpful output option is the frequency table. This will allow you to obtain counts of records meeting certain criteria, and you can run a frequency table for each specific event type in NHSN. So for example, if you want to know how many VAE events are classified as probable VAP in the ICU, you can run a frequency table, you select a row variable and a column variable, and this will let you get counts that meet each of these two criteria. And as a second example, if you want to know how many CDI lab ID events are categorized as community onset, you can also run a frequency table. So I'm now going to talk about how to review your data in the SSI SIR and ensure accuracy and quality. So it's important when you first run your SIR output to look at all of the variables we provide you and ensure that your procedure count and your infection counts are accurate or is what you would expect. Keep in mind that certain procedures are excluded from the SIR calculations, such as if they have missing variables or an outlier value. And the SSI event is excluded from the SIR if the corresponding procedure is also excluded. So when you're looking at your output, if you notice that there's a discrepancy in the procedure count, scroll to the very, very bottom of the SIR output. There is a table called Incomplete and Custom Procedures Not Included in the SIR. And this table will show you each procedure, the procedure code, and any infections associated with it that were excluded from the SIR. And note that the procedures in this table are only showing those that were excluded due to the exclusion criteria in our 2010 NHSN newsletter. And this exclusion criteria is to alert you to potential data quality issues. So you may ask, why were my procedures excluded? Some possible reasons for exclusion. You may be missing an important risk factor variable for some of the procedure categories. Your procedure duration may be less than 5 minutes or greater than our predetermined cutoff point, which we call the IQR5. And each procedure code has its own IQR5, which can be found at the bottom, this link here. Appendix C of the newsletter will show you each procedure category and its maximum duration that that procedure can have to be included in the SIR. Also, if the patient age entered was greater than 109, and if the procedure date is on or before the patient's date of birth. So this is us just trying to alert you to potential data entry errors. It should be rare, so hopefully your list of excluded procedures is short. And again, you can find a complete list of exclusion criteria in this newsletter here. So if you see that you have excluded procedures and you want to know exactly why that procedure was excluded, you're going to run the line listing for excluded procedures. This can be found in the Procedure Associated Module folder. Under SSI at the very, very bottom, you see line listing, procedures excluded from the SIR. You're going to want to modify this line list and limit the line list to the procedure codes and time periods of interest based on the SIR that you had just run. And you can add important variables based on that procedure category. So here is an example of a list of excluded procedures. In our example, we had one colo and one HIST procedure excluded from the 2013 Q1 SIR. So this line list shows that the procedure durations for both of these procedures was above the determined cutoff points, the IQR5. So for colo, the IQR5 is 668 minutes or 11 hours and 8 minutes. And for HIST procedures, the cutoff point is 479 minutes. So if you run this line list, you notice that the procedure duration is above our cutoff point. If this is a data entry error, you should go back and edit the procedure records for both of these procedures and click Save, and of course regenerate data sets. But if this is not a data entry error, you should know that these procedures will still be excluded from the SIR. And even though they're excluded from the SIR, these records are still reportable to NHSN. So some other ways to troubleshoot your SSI SIR. You want to make sure that you have generated data sets after any data entry or import, and resolve all outstanding alerts on your home screen. So for example, if you had no SSI events for procedures performed during a month, you must check the No Events box. And I know this is probably starting to sound repetitive, but we really want to drive this point home, that these data, until you check that No Events box, the numerator and the procedure count data will not be included in the SIR. So definitely want to pay attention to those alerts. Don't just ignore them. Make sure they're all clear from your home screen before you go to generate any of your SIRs. So another item to keep in mind, we have 3 different models that we use to generate the SSI SIR, and you really want to pay attention to which model you are using. So Maggie showed a version of this table in her slides as well, and so just again, this is something for you to look at. If you feel like your SIR is not what you're expecting, it's a fewer procedure count or fewer events are shown, each model has different inclusion and exclusion criteria based on this table here. So for example, if your SSI event count is less than you're expecting, you need to keep in mind which model you're using. And in this example, you can see the SSI event, the specific event is SIP, which is superficial incisional primary. And the complex AR and the complex 30-day models will not include superficial infections. So therefore, this event would be excluded. And this, again, can be found in an SSI event line list. So if you find that there are other procedures not included in your SIR that cannot be explained from that exclusion criteria in the newsletter, you want to read the footnotes below the SIR table for additional reasons that your procedures may be excluded. You can also run a procedure line list, which is found in the advanced folder under procedure level data. And this line list will help you determine the exact cause of exclusion. So for example, the complex 30-day model that we use for CMS only includes procedures performed on adult patients greater than 18 years of age. So if you run a procedure line list and you add the age on proc date variable, which is highlighted here, you can see that several of these procedures in this example were on patients under the age of 18. So therefore, it's going to be excluded from the SIR. And as a second example, If your closure type equals other for any 2014 procedures, those will be excluded from the SIRs as well. So we're going to switch gears a little bit and talk about the CLABSI and CAUDI SIR. So again, when you first run your SIR output, you want to look at all of the variables very carefully. And if your central line days or your infection count is lower than you expect, you want to look at the location-specific SIR table, which is going to be that second and third table in the output. And you may notice that the SIR is not including all of your locations that you've reported data to. And this is because the SIRs can only be generated for those locations that we had enough data during the baseline analyses to include in our aggregate pool. So certain locations will always be excluded from our current SIRs using our current baselines. And this includes telemetry wards, mixed acuity locations, acute stroke wards, burn wards, and some of the oncology wards. We recommend, if you are reporting data in these locations, to look at the rate tables to track internal HAI incidents in these locations. And just to note that we do expect to include more locations when we rebaseline these SIRs. So there are separate tables in the CLABSI SIR output that will show you the data from excluded locations, as well as any months with 0 or missing device days. And as you know, or you may know, that months with incomplete denominator data are excluded from the SIR. You will get an alert if that data was in plan. And if a location has 0 device days for all 3 months of the quarter, it will not appear in the location-specific SIR output table. You can only find it at this bottom table. And this is an important point for groups. If they're reviewing a facility's data and they notice that a location is not in the SIR table for that facility, it may be that that location was temporarily closed for the quarter. For whatever reason, that location had no patients for the whole quarter. The IP would have gone in and entered 0 for device days, so they did report their data, but they entered 0, so it's not going to go into the SIR, it's just going to go to this bottom table. So make sure to review all the tables in the SIR output and not just the first one. So months with incomplete or missing denominators can be found on the incomplete summary data screen, and this is for in-plan data only. If you notice that you have missing or incomplete denominators, you'll want to edit and resave these summary records. And this list and the alerts will only show you those months when at least one event has been entered. So if you have entered no central line days and no events, you will not get an alert. And that's just the way that the system was designed. And again, anytime you make changes to your data, you need to regenerate data sets before running any of the analysis options. Okay, so I will now talk about the MRSA bacteremia and CDI lab ID SIR. And we get a lot of questions on these, so I'm hoping that this will help everyone. So here's a sample output of lab ID SIR, and you notice there is one row of data for each quarter. There's also a months column, and you want to make sure that that months column equals 3 for each quarter, meaning that you have completed your reporting and entered data for all 3 months of the quarter. You also want to check the number of patient days and the number of events to make sure that this accurately represents all of the data in your facility for the entire quarter. So there may be a time when you have an outlier prevalence rate. And in this case, the number of predicted infections and the SIR, as well as the statistics, cannot be calculated. And this occurs if your community onset prevalence rate, which is the number of community onset lab ID events divided by the number of admissions, is above our predetermined threshold. So for MRSA bacteremia, that's 0.88. For C. difficile, that's 1.78. And these we came up with when we first risk adjusted the data. They're very, very high for a prevalence rate. So if you do see this, it really is a key indication that you should go back and make sure you've entered all of your data correctly. If this does happen, though, and all of your other reporting requirements are met per CMS guidelines, these data are still considered complete and still will be sent to CMS. So let me show you what I'm talking about. So for 2013 quarter 2, the second row in this table, you can see that all of those variables are set to missing. If you scroll down to the second table, which is titled CDI quarters with an outlier prevalence rate, you can see that in this facility for quarter 2, they had a CDI prevalence rate of 2.12. And this table gives you the opportunity to check that your number of admissions and number of community onset events were entered accurately. Again, should be representative of the entire quarter. So as a reminder, I'm going to talk about which events are counted in the lab ID event SIR numerator. So for MRSA bacteremia, this is only hospital onset events from blood specimens. And for C. difficile, this is only hospital onset incident events. So just a quick note, if a patient has a second lab ID event from the same organism within 14 days of that first event, the second event will not be counted in the SIR, regardless of whether or not that patient changed locations between the two events. The second event will not be counted. On the facility-wide level, it's considered a duplicate event, and we therefore take it out of the SIR. So if you're running your SIR and you would like to know exactly which events are being counted, you should run a line list or a frequency table to review these events. So here is a sample line list for MRSA bacteremia. You want to make sure that this line list is sorted by patient ID and specimen date, so you can easily see which patients had more than one MRSA bacteremia event. You also want to pay attention to the onset variable and those events where onset equals HO, which is healthcare facility onset. Those are going to be the ones that are counted in the SIR. If you are looking at your C. difficile SIR, you can also run a line list, but if you're just looking for that count of events, it will be very easy to get this from the frequency table. You should select CDI assay and onset as your two variables for the column and the row variable. And those events where CDI assay equals incident and onset equals HO, that is your numerator for the SIR. So I'm going to walk through an example of a hospital that is investigating their MRSA bacteremia SIR for 2013 quarter 3. So in preparation for the quarter 3 deadline, we would like to ensure that our data will be sent to CMS and that they will be complete and accurate. So the first few steps we want to complete before we even run the SIR report, we need to make sure that the CCN is accurately listed in NHSN. This ensures that your facility's data will correctly go to CMS. You also want to make sure you've entered all of your MRSA events and summary data, and make sure that your MRSA bacteremia reporting for the FAC-wide in location is listed in the monthly reporting plans. You want to clear all alerts from the home screen, and of course generate data sets. So when we want to see which SIR data will be sent to CMS, we go into the advanced folder under CMS reports, and in this case we're going to run the SIR MRSA blood FAC-wide and lab ID event. So here's a sample output for this facility. Again, we're focusing on 2013 quarter 3. So the first thing we do is we look in the months column. We see that, okay, there are 3 months of data. It's looking pretty good. We check that the total patient days are accurate for our facility for all 3 months of the quarter. And in this case, the IP is saying, I know I entered 6 hospital onset MRSA bacteremia events, but why are only 3 being counted in my SIR? So we want to check event level data in this case, and so we're going to run a MRSA lab ID line list. You want to modify this line list and add specimen date as one of the sort by variables. This will again help you identify any patients that had duplicate events that will be taken out of the SIR. So here is the sample output of the MRSA line list. You notice that there are 7 MRSA bacteremia events, and 6 are identified as hospital onset, as the IP had thought. But notice that there are only 3 patients. There are 3 unique patient IDs, which means that each patient has had more than one event. So in this case, you need to review each event and see if there has been 14 days between the first and second event. If there has not been 14 days, then the second event will be excluded. So in this case, the second event for each patient was within 14 days of the first event, and so these 3 that are lined out are not counted in the SIR. So I just wanted to take a minute to let you know about some new SIR troubleshooting guides that we have. I believe they are printed in your resource manual. They are also available on our NHSN analysis webpage. And these guides provide you with guidance on common problems that you may experience with all of your HAI event SIRs. They are one-page documents that you can review when your SIR is not what you expect, whether that's missing numerator counts, missing denominator counts, some of your locations are excluded, or if the SIR is just not being calculated, go to these documents because they will walk you through several scenarios and help you figure out what's going on. So I'm now going to spend a few minutes talking about rates for the inpatient rehab facilities and long-term acute care facilities. So in my example, I'm going to focus on county rates, and these apply to both IRFs and LTACs. We have checklists and helpful guides available for both of these facility types available at this link. So step 1, if you are a freestanding IRF or LTAC, you need to review the facility info screen and ensure that the CCN number entered is correct. From the left navigation bar, if you click Facility and then Facility Info, it will take you to this screen. If you're an IRF unit within a hospital, you need to review the Location Information screen and ensure that the correct CCN number is listed. So step 2, monthly reporting plans. We need to review all monthly reporting plans for the 3 months in this quarter and make sure that our locations are listed with the county box checked. Step 3, investigate alerts on the home screen. You may see alerts if you have incomplete or missing summary data, or if you have no events reported for a given month. You must make sure that you check that no events box. We have some updated guidance on alerts that was just recently posted in the NHSN newsletter, and it can be found here on page 6. So step 4, generate data sets and run analysis output. After all the data have been entered, you want to generate data sets, and we do have specific output options for IRF and LTAC quality reporting found in the advanced folder. And these will show you the rates that will be sent to CMS. So here is sample output for LTAC. A single table is shown in the output, and it's showing you the county rate for each location and each quarter. Again, you want to review all of the variables we show here. You can notice in this example, for the PEDS LTAC ward, they only have 2 months of data, and that should alert you that some of the data is missing. If you run this output and you notice that the number of infections is too low, the first thing you want to check is if there are any alerts on the home screen, because a lot of times that will solve the problem. If not, you can run a line list of county events to review the specific details for each event. And for county events, remember that the urinary catheter variable must be equal to in place or removed. And if there are events in which the urinary catheter equals neither, those are not considered counties and will not be included in the county rates. So if needed, you can edit the event record and regenerate data sets. If the number of device days is too low, again, make sure there are no alerts on your home screen. Review the summary data you've entered into the application directly from that left navigation bar, or run a summary data line list in the analysis options. If you notice any problems in your summary data, you can edit the data and regenerate data sets. That will then update the rates in the analysis reports. And you want to ensure that data have been entered for all locations and for each month of the quarter. Okay, so now I'm going to talk about helpful hints for all facilities reporting to CMS for quality reporting. Before the quarterly deadline, that's the key part here, you want to run these CMS reports found in the advanced folder so that you can review the data that will be sent. It's also very important to save or print these reports for future reference. So remember that any changes or updates you make to your data after the deadline will never be sent to CMS and will not be reflected on those preview reports or on Hospital Compare. But those changes are going to be reflected in NHSN analysis and in the CMS reports in NHSN analysis. So a lot of times, a facility will get their preview report and then we'll go right into NHSN and try to make sure that the data match up. But if you have made any changes to those data since the freeze date, your data, you might find discrepancies because those changes will not have gone to CMS. So again, if you had printed or somehow saved the CMS reports at the time that you ran it before the baseline, that's what you should be comparing to your CMS preview reports. And of course, give yourself enough time to enter and review data before the quarterly deadlines. So just a reminder that your data can be exported. You can export your NHSN data sets to view and analyze on your own. You have several formats available to choose from, including Excel, CSV, Access, and SAS. And we do have a quick reference guide on how to export your data. So that is all I have today. I entered early for you, but if you do have questions, I am happy to take them now. And if not, don't leave yet because we have a few announcements.
I have a quick question for you.
Yeah.
You said in the MRSA Lab ID event line list page where you'd crossed out the duplicate MRSAs. The last one wasn't crossed out, and I just wondered why.
Sure.
It was 14 days exactly since the first event, but it was less than 14 days since the second event. So we're using different rules for what we report, so I just wanted to clarify with the exclusion on that side.
Okay, so you're talking about the patient in the blue box.
Correct.
Right? So that third event, you see the date that the specimen collected was August 14th. And that is 14 days after July 5th, which is the event above it that's crossed out.
Oh, sorry, I was looking at June. Or I was thinking it was the same month. Thank you.
You're welcome.
So, but that's excluded just because it's so far after.
Yes.
I was wondering, do you have a projected date of when LTACs are going to have some SIRs available?
This is something that we are discussing. We know that you guys really want to see an SIR, and it's not going to be any earlier than the next few years, at least in 2015. We are aware of it.
I have a question for you.
Yes.
Nancy from Oregon. So on this report here, why wouldn't the system pick up the dates and just toss that out themselves? You know.
It's because of the protocol and the way the protocol is worded for Lab ID events. So if, in this case, you can see that the patient changed locations for each of those 3 events. And in the protocol, if the patient changes locations, you have to enter that first one in the new location. You're welcome.
We knew that we'd be done a little early, and we've been listening to the questions that you've been asking over the past 2 days. And because you've been asking some questions about CMS and reporting, I wanted to give you the opportunity to ask me some questions because one of my big responsibilities in my position is to be the one to work with CMS on their rule writing and how we get their rule data into NHSN, how we package it, send it, what our timelines are, anything that I could talk about for the future. It's not in a rule yet, I can't, but you just asked Lindsay the question about analysis. I'll go back and answer that. So I'll try to feed you some information based on the questions I've heard, but because we have a little time, if you want, I wanted to give you the opportunity to ask any more of those questions that you feel weren't answered yet. Again, you saw the number of us who are working on all these detailed topics. So there isn't one person who can possibly know everything. We all have our areas of expertise and we depend on each other for some of the other aspects of it. So I wanted to be able to fill in that aspect for you of what I do. Admittedly, and what I probably will plan next year is to have a separate session where I can cover it for you. Didn't anticipate or tie in how these questions are all interlinked with what we're trying to present and how you have to fold that back into what you need to do. So I'll take questions now. I'll be around tomorrow as well if you think of something or more come up. I can do this again tomorrow if we have time or on the side during breaks. And we'll make sure we incorporate something like this in next year's training. So in that way, thank you for your feedback and your questions because that's helpful for us to keep improving. But there's one important thing they asked me to say first, and that is there's a lot of the turning point clickers that are out there, and we need to make sure that those get turned in. And I know they get slid under things and put in, from pockets or something. Please just try to remember to make sure that those get turned in. Another thing is that please make sure that you scan out when you leave today and make sure you, sorry? Oh, is there a question? Okay. And scan back in the morning when you come in because we need you to do that. And I think, I know it might get backed up a little so people are forgetting. People have asked about evaluation forms and we will have those tomorrow for you so you'll be able to complete those tomorrow. We do know that you'll all be checking out tomorrow on your way here, and we'll have luggage bags. We can check all of those in here and accommodate, but keep in mind that in order to keep track of your bags, we do have to, have some order to do that so you don't take a wrong bag home. So just make sure you have that time built in so that you can get in, get your bag checked, and still have everyone in the room here so that we can start at 8 o'clock. So that we can get you out on time. We're ending early tomorrow, but we do have a lot to cover tomorrow as well. So keep that in mind when you're heading in the morning. And we also will help and aid with all the transportation to the airport. And we will be doing that tomorrow when you come in and throughout the day. Courtney just asked me to say that if you're leaving early before the end of the sessions because you have an earlier flight, please let us know when you check your bag in the morning, and they will help coordinate making sure that you can get out of here on time when you need to. I think that covers it. If there's anything, Courtney, that you think of, just tell me before I end. So I'm going to try to cover some CMS issues for you based on questions. So the LTAC question, since that just got asked and it's fresh in my mind, when new facility types begin reporting, we always need to accumulate enough data from that facility type. Again, the SIRs are based on a baseline and risk adjustment. We're not ever going to make the assumption that one facility type looks like another, so we just throw them into the other risk adjustment analysis that we've already done. Meaning, yes, we have CLABSI and COUTI for acute care, but we weren't going to assume LTACs look the same and use that. So what happens then when we work with CMS and they write in for reporting and not value-based purchasing or anything, and they don't signal a date for public reporting, it's because they're giving us enough time to collect the data, they're giving facilities enough time to get used to reporting the data, and then we can accumulate that baseline year of data that we then believe is reliable and accurate, and then we can perform the risk adjustment, do the analyses taken for that specific facility type, produce that baseline, and then it would be the next year that would be the first SIR produced to the baseline. So with LTACs and IRFs, LTACs, CLABSI and COUTI, IRFs for COUTI, they began reporting only in the fourth quarter of 2012 and all of 2013. One quarter in 2012, we're just sort of looking at them getting used to and being set up. So we're using the 2013 data as their baseline. And you know that the way the 4.5-month reporting dates go, we're just going to get the final 2013 quarter 4 data after May 15th. So we will be looking, and Maggie and Lindsay are the main leads on that analysis, be looking at those data coming in when they're final to start looking at the risk variables we have for those facility types to start doing those analyses. And again, LTAC will be separate from IRF, which are separate from acute care when we look at the data. So we will have that SIR that can start being produced. So you would see that if you're at a facility in a preview report, we will use the 2013 baseline to start producing the SIR on 2014 data. Now with IRFs, the first quarter of 2014 isn't due till August 15th, so that gives us time to produce that SIR and have that be out and produced for that first feedback on that quarter. For LTACs, as you know, they shortened the timeline. So in 2014, they only have a month and a half to get their data in. And this is important to remember to health facilities that quarter 4 data from 2013 and quarter 1 data from 2014 for LTACs are due on May 15th together. So LTACs have a little bit of craziness in this first time because they're overlapping an old rule timing and a new one. Also because of that, the data we need to do the baseline is coming in at the same time we're supposed to be producing the SIR from the baseline. So LTACs for quarter 4 will get will get a rate just like they've been, but then we will go back and change that data to an SIR by August 15th to sort of bring them up to speed when we can catch up. We just need those extra months that the IRF timing gives us, but the LTAC doesn't, to be able to start producing an SIR for the quarters in 2014. Now, that being said, the hospitals are going to be getting their SIRs. But it has not been signaled yet in rule when that is going to public reporting. But now that we're moving to the SIR, CMS can get ready to signal public reporting. So that is up to them, not us, when they choose to say now LTAC and IRF data would be shown publicly. But at least now that we have the SIR, they will move in that direction. And again, I'm not speaking for CMS. I'm not dating or promising that. Again, that's them. All I can say is we have told them our timeline, and they know that these hospitals will be getting SIRs. Tying into that CMS always hears from us as well, so they take this into account when they're going to move new hospitals to public reporting like the LTACs and IRFs, is that we have told CMS, and you have heard it even all the way back to Dr. Dan Pollock yesterday morning, we are trying to stabilize the definitions. We know that there are some changes in revisions and to make things a little bit better that we need to do. We also have the whole electronic reporting move strong on our minds. So what we are trying to do is take all the input we've been getting for the current definitions and do the revisions that we can for now on the mostly manually entered definitions as they are and as they stand now, and make those changes in 2015 so that after that the data stabilizes. And we will try to stop making small changes and tweaks to definitions so that you know what you're working with. And then our plan in our minds is to say, after we touch everything and fix it and try to stabilize it in 2015, if there comes another change, and again, it doesn't mean there isn't going to be anything small, but any major plan or revision to revise definitions in any larger way is going to be a strong move to electronic reporting and data capture. So we're looking at 2015. We're saying that we're going to rebaseline, which means no more CLABSI to 2006 to 8 baseline, no more COUDI to 2009. We're going to bring all of the HAIs up to 2015 baseline to produce SIRs from there. And the next time we would rebaseline, hopefully, would be when we're doing a major move to electronic reporting, use of CDA, so that it removes that burden of manual entry and a lot of specific digging into charts. So I can share that vision with you and say that that also feeds into CMS's decision on, well, do we want to start publicly reporting this LTAC and IRF data? If you're going to give us 2014, but then you're rebaseline in 15, maybe we should just wait. So those are the things that we discuss with them to say, if you're rebaselining and you haven't started yet, maybe you should wait until the rebaseline and then just put out those fresh SIRs. Because, admittedly, we do have to work through and do analysis to figure out what that shift is going to be, because we also know that that affects CMS and anything that might be in value-based purchasing to say this is the performance baseline, this is the baseline year, the performance year, and now you're measuring apples and oranges, so we have to deal with that as well. Again, not easy issues, but I'm just trying to share this with you so that you sort of have a feel for all the little pieces that come together that have to be worked through to try to make it work for everybody. So that's one of the major things I picked up. There were questions about ICD-10, but Janet covered those, and I think you have a good feel for what our plan for the ICD-10 codes and what we can do with those. What was the, Janet, there was, oh, thank you. So the Medicare beneficiary number is one of the requirements that's in rule that hasn't happened yet. So CMS signaled in their final rule that the requirement will begin this July 1st for acute care hospitals to report the Medicare beneficiary number of a patient who would have one because they are a Medicare patient whenever you report an event into NHSN. We have that field available on all of the event forms. It's not required because it would be very difficult to require it and then say, what about all the patients that aren't Medicare beneficiary? What do you do in the line? So CMS chose to say, we keep it optional, but it's then upon the user in the facility to say when this patient is Medicare, in addition to the patient ID and the gender and the date of birth, you have to put in the Medicare beneficiary number. So nothing will change in NHSN, but we will put out reminders to say this rule is in place and CMS expects to see it as of July 1st. I'll qualify because we've had the questions that they are events. So they're the numerators, which means for SSIs, they are the SSIs, but not all of the procedures. And we did clarify that with CMS, that you don't have to put it in for every single procedure, only for an SSI that occurs and is identified from the procedure. So Janet said that there were some questions about the Medicare beneficiary number and what it is. I can't speak to it. If people are saying there's multiple numbers, those aren't our numbers, so I don't know, but I will tell you that I will look into it. So we will work with CMS. If you want to send a note, it would help us to the NHSN Help Desk to tell us specifically what you see or what the confusing names are called or how they look. Because if we take that question to CMS and say one's a 6-digit and one's a 10, they could look at it and say, oh, it's the 10, that's the one we use. So they will know what to tell us to then feed back to you. So if you give us that information, we'll get an answer, we'll make sure we put it in the newsletter, and anywhere else, APIC presentations, anywhere else we can share it. Again, it's going to be on facilities to remember to put that in, so we will continue to remind everybody to do that. And the only other thing I can say about that is I thought that they were referring to the HIC number as the HIC number as the Medicare beneficiary, and they have interused those two terms, but again, we will find out for you for sure, and we will give you the best information that we can get as far as guidance from CMS. So that covers that one.
Dawn, can I say something about the Medicare beneficiary number?
Sure.
I think probably where the confusion is coming is that with it is the HIC number. Okay. But when you're abstracting for the IQR and OQR measures that go on into QualityNet, the specification manual that is out on QualityNet defines what a valid HIC number is. And like if they have Railroad Medicare or they have a Railroad Medicare would be a valid HIC number, but if you were trying to put in a Medicare replacement plan, like an HMO Medicare, that's not in a valid format. There is in the data dictionary,
Okay.
It defines what a valid format is. So that would probably be something for you all to look at
Okay.
in
That's
that
very
conversation.
helpful. Yep, thank you very much. And so sure, that's great. If there is a solid format of these are and these are not, we can show that to you and help you through that. It's sort of the same thing as the CCNs, where when we brought the LTACs and IRFs on, we looked in the guidance and we knew that CCN numbers between this and this, these were the LTACs that qualified, these were the IRFs that qualified, the IRF units have the T or the R in the third position, that sort of thing. So we will follow up with that as well and try to get that exact guidance.
Yeah, I had clarified that with CMS prior to some training that we did in our state, and that's just exactly what she said. It's not there. It's exactly what the specifications manual it says. I guess the question that I had is that I think that you could be of help in being our advocate going forward, is that in determining what exactly is going to be publicly reported for the SSI number. Currently, we have encouraged to look at what is on Hospital Compare as our state's number. And in the next week or so, DHHS is going to put out report cards, and they're going to use the complex AR number for SSI rather than the 30-day. And they're very different. And it's going to make our state look like, like we have a problem. Much more of a problem than what we were saying. Well, we're right at an SIR of 1.
And you're talking about the progress report that we put out?
Yeah.
Okay.
So I think that's going to be really confusing. We want to be transparent about our numbers and what we are, and they're doing and it's a nice document. They're trying to make it simple so that patients and everybody understand. But that's very confusing. There's no way they're going to understand the difference in the risk variables because it's a different way of calculating the statistic.
Right, I see. Okay, thank you for that. I think what we just need to do and be aware of is the messaging that we can put on anything. So we might be able to even look on Hospital Compare and put some messaging in there because they give us opportunities to update the paragraphs to the HAIs. If there's footnotes and extras that we can put in there to even reference, please be aware, this is calculated off of this and this. And then if we in turn in the progress report, I'm sure it's explained in there, but if there needs to be a couple more sentences to say this will vary from other reports because we can do that.
Yeah, it's like when they get different reports and it's different samples, different whatever, and we're calling it the same thing. That doesn't help the public understand what we're doing.
Right.
So
Thank you. Thank you for that. And I'll say, we actually talk about that every day with the transparency that Dr. Pollack talked about and that Dr. Cardo talked about. It's the same thing where there's a lot of people that want the data and they want to see it. And we have more pressures to say, show the data, put it out there, let people look at it, make sure they can see anything and everything. But those are the things that are under consideration when we do that. And with all these reports is that everybody can look at it from a different angle. I mean, you yourself know that states can analyze the data very differently than the CDC does, even without CMS in the picture. And again, best we can do, because that's not going to go away, is just be clear with the messaging of what goes into that analysis. But you're right, it's very hard to try to get that message to the public who doesn't work behind the scenes with the data every day.
And I guess the other thing that I've heard frequently, and I think that showed by a show of hands here on how many people are putting in their joint patients into the system versus the CMS measures are based on claims. And I think the physicians and stuff that we work with really trust the NHSN database and the information there a lot more than the claims data. And we're already doing that work. A lot of them are. So let's use it for the measure, I guess is the thing that I've heard from them.
Right. Well, thank you. I will take that and leap back because there was a question that was asked while Janet was speaking about that as well and the risk adjustment. I addressed it to the individual who asked the question, but in fairness for everyone to hear, we do, and Janet explained this, we have to harmonize the measures that we work with CMS when we are asked to bring a measure through NQF and get it approved. Again, you heard us say very early yesterday in the morning that in general, CMS needs to and will only work with NQF endorsed measures or measures that they know are moving towards NQF endorsement. Dan described the NQF group and how they work and semi-government regulatory and that sort of thing because of that. So when we were asked to look at the SSIs and specifically to begin with looking at colo and HIST, we went obviously to the American College of Surgeons to work with them and collaborate with them. Again, to work with all of their surgeons and the experts in that field so that we could get their input. You're also probably all aware that the American College of Surgeons has the NSQIP database, and they do their data collection, and they have their own collection and analyses and output. So when you're talking about two surveillance systems that need to come together to agree on one approved NQF measure, because there can't be two and there shouldn't be two, because that would be even more confusing, we had to harmonize. And in order to do that, we had to say, yes, they agree on a bunch of variables we didn't collect, and we agree on variables that we had that they might not collect. So the best we could do to begin with down this road is to look at the variables that were defined the same and collected together that would begin this process and harmonize the measure that would give a good indicator. So the American College of Surgeons, with us at the CDC, agreed that this would be a very good starting point measure. It doesn't mean that there wouldn't be expansion. We're also still continuing talks and trying to figure out how one set of data can feed into the other, again, to try to be aware of the double manual entry and things like that. So again, just to make you aware that all of those discussions are underway. I know you might not always hear about them, but we do work with the experts and try to do that. There will be other measures, perhaps SSIs, that we are working with other groups that also have their own coding and systems. We will have to harmonize with them to get an NQF endorsed measure, and that's a good starting place to then go forward with the two groups working together. So it's not that we don't recognize that more variables are important. It's why we added diabetes and body mass index to the SSIs and made them required beyond just C-section and that sort of thing. So we know that we're going to look to it, again, as part of the updates to 2015, to be able to analyze other variables, to look at risk adjustment, and perhaps move things into the future. So we get it. We're not stopping there. The conversations are still underway. But in order to keep moving something along, we didn't want to wait 5 years before we came to something that was perfect. We're starting with this that the experts agreed upon, and then we'll move from there.
I had a question. I work at a level 1 trauma hospital, and a lot of physicians with our colos particular that we have to report, they get upset when it's a class 3 or a class 4 that they're getting tagged, with an infection that they're saying they were already infected when we went in, or it was, perforated gut or something like that. And they were wondering what that means for like reimbursement purposes from CMS.
So, and did I hear you say, because I want to make sure I don't mess it up, that they're infected during the surgery at the time of surgery?
If it's a class 3 or a class 4, it's a trauma or something like that,
Right.
That they're saying you're going to expect probably an infection. So, it's not really a surgical site infection that they caused.
Right. So I'm not going to mess up and step on anything in Janet. So if you want to jump in, you can, feel free. But I will say that we are adding the variable, and Janet talked about that, about present at time of surgery. So that right there is going to be something that we are definitely taking into account. That's an addition for 2015 variable. Again, that starts going into risk adjustment and plays into our decision on whether we remove those and what we do with them. So that variable allows us to make that determination. We're not there yet, but that's our intent with the recognition and the feedback that we've received. Okay, thank you. So the PATOS definition, as Janet just said, is based on the NSQIP definition. So again, we're harmonizing to use the same definition to move forward. So it will be in there, and again, heard it, working on it. SSIs, we worked with a very large group of subject matter experts and then sort of spanned things out over the course of 3 years to be able to implement them accordingly. 2015 is the last year of those decisions we made, and that's one of the last ones to be added. So again, these are the questions I've heard and wanted to make sure that we could give you as much information as possible. And again, I'm sort of, winging it off the top of my head, but do you have any other questions at this time? Feel free to ask. Again, if you think of something, I'll be around tomorrow. If I think of anything that I feel like you might want to hear that we haven't covered, I will try to have time to bring it up tomorrow. Again, when we signal things and when we can, know about something, please read our newsletters. We don't always have, this is great to have you in the room, to have all the individuals watching the live web streaming. We don't always and usually don't have this opportunity. So the way we can reach out to you to try to keep you updated as much as we can is the newsletters, and we really will try to do that. We are going to make sure that we try to signal as early as we can the changes that are coming in 2015. Again, not to give you the idea that every definition is changing as a complete overhaul, but we are touching things. So there's little things that add up. There might only be 2 things in SSI, but there's going to be a couple things in COUTI. We're changing the Chapter 17 HAI definitions to help with the secondary BSI determinations and things like that. There'll be, a couple little nuances added in, trying to consider a denominator simplification so you don't have to count every single day, perhaps, if we can guide on which days to take the counts on and put it in the system and let the calculator do it for you based on some of the research and work that other groups have done to feed into us that this would be possible and it would eliminate some burden. So again, try to indicate those upcoming changes as early as we can. We wouldn't signal probably before June, but once we get into June, we'll have that newsletter. We'll also have APIC, which is another big conference where we present a lot of the detailed information. And so that's when we're going to try to be ready to start signaling over and over again for the coming year in 2015, feeling like you'll have 2014 completely all stabilized and going smoothly. And, we'll have to start talking about 2015 at that point.